Thank you very much. Thank you for the Society for asking me to do this. I'm not entirely sure why I've been asked to talk about radial artery. I don't think I'm a particular expert on it, but I'll try and give you the best view of what I feel is the current status with this. So just kind of a bit of history. That's the first report from Alan Carpentier back in 1973, showing their experience with the radial artery conduit, and probably most of you all recall that it kind of fell into disrepute after that. They were not sure about the end results until, again from Paris in 1992, Christopher Carr reported on their experiences and concluded that the radial artery was probably a reasonable the left internal mammary artery. So I guess the questions we want to ask ourselves and perhaps try and answer today is, what's the place of the radial artery in the spectrum of different conduits? I'm only going to restrict myself to the vein graft, the IMA, and the radial artery. And is there a biological comparison between these conduits? I think that's what the questions we're asking ourselves. We're not going to talk about the lima to the LAD. I think that's the gold standard. And I know David Taggart talked about the bilateral mammary, and he's got some other data perhaps later on. We're not going to touch about that either. So why use the radial artery? Perceived advantages, as probably we all know, are it's an artery, so that's good. It's comparable diameter with an excellent length. It appears to be and superior healing of the forearms as compared to leg wounds. The concerns about its biological behavior, being a muscular artery, are it's prone to spasm and appears to be vulnerable to competitive flow. So I'm going to touch on data from three main areas, Rome, Melbourne and Paris, to try and answer some of these questions, a bit from the States as well, but Torsund is going to talk about that a bit later. So we'll start in Rome, and this was really the first paper from Bossati in 2003 that looked at some of the longer-term results of the radial artery. In summary, it was 90 consecutive patients, so this is non-randomized. All patients had at least a lima to the LAD, and the radial artery was then grafted to the secondary target vessels, and 48 went to the obtuse marginals and 30 to the posterior descending branches. All radials were anastomosed to the aorta, so no composite grafting here, and saphenous vein grafts were used for the rest of the grafts. And the longer-term follow-up, angiographic follow-up, and this was done at a mean of 105 months, which equates to about just under 9 years, shows extremely good results for the IMA, as you would imagine, 97.5%. The radial artery was 91.6%, and I guess not surprisingly for the vein graft, 67%, although these were now being used for third-order grafts, if I can call them that. What was interesting, and which came quite clearly from their first experience, is there was a direct correlation between radial artery patency and the stenosis of the receiving vessel. So the tighter the lesion, the higher the patency. When they looked at whether calcium channel blockade helped in longer-term patency, they divided them into two groups. One calcium channel blockade was continued for 12 months and then suspended, and there was no difference between the two. So the effect of long-term, by long-term being more than 12 months calcium channel blockade, does not appear to have any significant difference. So the overall conclusion was that the radial artery patency was excellent at 10 years, about 10 years, and the vessel appeared to be resistant to progressive atherosclerotic disease. There was no benefit from continued calcium channel blockade, and patency appeared to be dependent on an adequate technique and avoiding competitive flow. We then go to Melbourne, and Brian Baxton's work with the radial artery patency and clinical outcome study, the RAPCO study, and the five-year results were published in 2007. Kind of a little somewhat strange trial in a way, in that it is two trials with double randomization, at least 2 grafts per patient with to the LAD, and then a study graft, the randomized conduit to the next best target with other conduits if required according to the surgeon's preference. And the randomizations were into two groups. For patients less than 70 years, it was the radial versus the free IMA, right IMA. And for the patients over 70 years, was the radial versus the venous vein. The clinical endpoints were survival and then event-free survival, looking at myocardial infarction and any form of further revascularization, with annual clinical review and confirmation of death from the Australian National Death Index. For group 1, if we look at clinical outcomes, radial versus free IMA, their actuarial survivals showed absolutely no difference. For group 2, similar, no difference. When you looked at the angiographic data, patency for the in situ arterial grafts was 96%, again not a surprise. For the free arterial grafts, 89%, and for the vein grafts, 82%. Significant difference between the in situ and free arterial grafts, but no significant difference between the free arterial grafts and the vein grafts. Into a bit more detail, both Lima and Rima as in situ grafts, very good patencies, radial marginally better than the free IMA, and the vein graft at 82%. Their actuarial patency probability is as shown, showing perhaps that there's going to be some divergence later on beyond 7 years. Slightly more later data, this is at 7 years rather than 5 years, again shows no differences between patencies of radial versus free IMA or radial versus venous vein graft. So the overall conclusions to date of the RAPCO trial are that there are comparable angiographic outcomes at the mean of 6 years. The radial arteries are performing equally well in younger and older age groups. The numbers at risk beyond 7 years reported so far are small, and so we're awaiting with interest the 10-year angiographic follow-up. The clinical outcomes appear to mirror the patency data, so survival and event-free survival appear the same in both groups. The somewhat surprising thing so far is that the vein grafts are outperforming historical expectations, and that the free Rima performs less well than the in situ Rima. We then go to Paris again, and Christopher Carr has recently published their 20-year experience of 819 patients. Their mean follow-up, clinical follow-up, is at 9.2 years, is for just under 70% of that cohort. And those are the number of conduits used, as you can see there, 2.45 grafts per patient. The angiographic follow-up is at a mean of 7 years in 43% of the total cohort. Their clinical outcome data shows good results. Freedom from cardiovascular death at 92.7% at 9.2 years, and estimated at 89% for 15 years, and similarly for freedom from revascularization, good results. The angiographic follow-up, again, interesting. This was at a mean of 7 years. As you would expect, very good patency for the IMA, 95.5%. And then the radial artery down at 82.8% with a significant difference, but no significant difference between radial free IMA vein graft. Some of the determinants they tried to look at of radial graft patency, not surprisingly, there was better patency in the asymptomatic patients. The target vessel appeared to make a difference, diagonal being better than circumflex, better than right. Sequential, when used as a sequential graft, appeared to do better, 91% versus 82%. And when used in an isolated cabbage procedure, they seem to do better than when used in combination with valve surgery. The very interesting, from my point of view, data is when they divided the same grafts over time, so over 4 cohorts, and you can see that the attrition appears to occur mainly during the first year, and indeed mainly during the first 6 to 7 months. Beyond that, attrition seemed to be quite stable in around 0.37% per year. So their overall conclusions from Paris, I think that CABG using the radial artery offers long-lasting clinical benefit. Beyond 1 year, radial patency appears to be very stable. They also do not see any benefit in continued postoperative calcium channel blockade. And once again, the main causes of failure, technical error and competitive flow. Again, fairly recently, the STS in January, this is a paper from Toledo, looking at radial usage in the elderly. CABG patients over 70 years with at least one IMA used, 480 patients, radial patients, propensity matched to their saphenous vein counterparts, well matched 75 years in both groups, 3.5 grafts per patient in both groups, identical 30-day mortality, 1.9%, but significantly worse late mortality for the venous group, top line in the top graph there, with a radial patency at 5 years, estimated survival of 85% as compared to 70.9% at 5 years. Again, their overall conclusion, radial artery as a second conduit may improve late survival and should not be avoided in the elderly. Our own personal experience, we've used the radial artery quite regularly since about 2000. In most instances, it's been used as a composite graft, and we find it very ideal for the off-pump aortic no-touch technique, which was described earlier this morning. This is an angiogram from one of our patients, 6 years post-op, with the IMA to the LAD and the radial going to the PDRCA, and another one at 9 years, picking up the circumflex on the way to the PDRCA. Initially, we used it exclusively in almost all our patients, but we had the very early realization of a negative impact of competitive flow, and we now never use it in stenosis which are less than 80% and preferably 90%. Meticulous harvesting technique. We still use amlodipine 5 milligrams daily post-operatively for 6 months. As far as the harvesting technique is concerned, we use electrocautery. The vessel is flushed, not dilated, with heparinized blood. Preferably we use phenoxybenzamine, but commercially that's not available at the moment, so we've reverted to GTN, and we keep the conduit in the solution until use. My own personal conclusions from all this: the radial artery is a very useful second arterial graft, has inferior patency to an in situ lima, probably BEMA. Radial patency seems stable in 1 year when used judiciously in the right conditions. Ideal for usage as a composite graft, extremely low conduit harvest site infection. And my conclusions as well: IMA failures seem to be largely technical, vein graft failures seems to be largely biological, and radial failures are occasionally biological but mostly predictable. Competitive flow is extremely important. The choice of how you use it, whether you use it in intercommunicating grafts or an unbalanced composite grafts, are also important. So that, thank you, I think summarizes my understanding of the current situation with the radial artery.
Thanks very much, Brian. I myself, I find the radial, especially the constriction bands, which even when it's taken as a pedicle, although when you flush the artery, you see a flow down it, but if you a closer inspection, you find these constriction bands, they're very difficult to get rid easily, and that's what sort of made me all the time wary of using the radial artery. I mean, I don't know with the technique of just flushing it, how you guarantee you can sort of clear all these bands.
I must admit we don't have any problems with constrictions. If it's taken down meticulously, we flush it. Particularly when you're using it as a composite graft, you do your TY graft first, and you just let it dilate slowly under the natural pressure of the system. Most of the time, it's done off pump, as you can imagine, what we do, and it's the normal pressure which dilates it, and it dilates very nicely in most occasions.
Can I just ask, do you skeletonise it on one side or both sides? Skeletonise. Do you skeletonise the pedicle on one side or both sides, dividing the fascia?
On one side.
Just on one side. Questions?